Thank you very much for inviting me. I'm going to talk about anesthesia for GI endoscopy. Now, if endoscopic procedures generally, when it started, were mainly restricted to diagnostic procedures, and they were fairly short duration procedures. And though they are short duration procedures and a diagnostic procedure, they can be fairly uncomfortable to the patient. If at all, if you're looking at some upper GI endoscopies, they're associated with a lot of, sometimes even if you like put some topicalized throat, it can be associated with gagging, choking, and retching, and vomiting, and laryngospasm. And if somebody is unfortunately have a colonoscopy, it basically causes a lot of discomfort and abdominal pain and discomfort while doing the procedures. If some sedation is given to the patient, or if they are made comfortable, it definitely increases the patient comfort as well as the operator's comfort as well. And probably there are enough studies now to show that if the patients are well sedated and comfortable during the procedure, probably the pickup rate, like what you need to diagnose, the very purpose for these endoscopies are being done, the possibility of getting something what you need to find out probably is higher, and the patient satisfaction is definitely higher. And more so, some of the unfortunate ones do come for repeated procedures. So the likelihood for the patient coming in for repeat procedures are much higher if they are sedated. Now, when it actually started for diagnostic, we see most of the time there is a little bit of sedation, and most of the time this is given by the gastroenterologist or the endoscopist. And they used to use probably pethidine and a little bit of diazepam or some sort of little bit of ketamine on their own. And anesthetists came into the picture for endoscopies much later, and in more so because one basically whatever procedures what we are doing, they are much more complex now. The duration is much more, there are more of therapeutic procedures being done in elderly population and as an alternative to open surgeries. So a lot of times in very critically ill patients where they cannot probably undergo an open surgery, a lot of these procedures are basically managed by doing this endoscopy. So that was one part. And secondly, with the advent of a lot of papers coming in about the use of propofol for endoscopic procedures. Now, a lot of countries with the FDA regulations, propofol is not licensed to be used by non-licensed people. For example, if you're not being trained to use propofol, and when I mean to say trained to use propofol, that you obviously, apart from the knowledge to use the propofol, it's very, very important to manage the complications associated with propofol. It's a fairly potent and a non-forgiving drug. We have seen with Michael Jackson what happened, right? If somebody is a non-anesthetist giving it, can cause a disaster if you are not used to. So with the regulation coming with the propofol, anesthetists started getting involved. And I think it was a good idea for us, that's all. Why not? I mean, if you are getting involved with these things, why not let our business opportunities improve? If at all, never learn to teach the surgeons to give propofol or to teach propofol. Nor teach them to put an IV line also, you know. Even they stand by it. Just get them for your business. I mean, you should not be putting your business forward now. So it was a good idea, and obviously anesthetists latched on to this. That's how all this discussion of these things. Having said that, now what they are doing it is now much easily on the other side, and there is such complex procedures, poorest patients that sometimes it's a pain. The moment some people are very uncomfortable doing these procedures in the out of the theatre, out of your comfort zone, because the complexity has increased and the duration. I mean, some of these endoscopy procedures go on for hours, 2 hours they do it, and then really test how much propofol you want to give, how much this thing, right? Really. So let us see some of the anesthetic concerns what we face doing these procedures. See about the preoperative. As any other procedure, whatever we're using preoperative evaluation, the goal will be obviously to identify any medical and physical conditions which would directly affect your. You can have a formulated anesthetic plan. More important, the physical exam will be direct from the anesthesia point of view, whether the airway, allergies, XYZ, EBC. And more important, need to identify drugs or factors which could probably increase the sensitivity to your sedatives and narcotics, especially obstructive sleep apnea, subclinical pulmonary hypertension, ischemic heart disease, chronic lung disease. These are the patients who are likely to give you problems, because a lot of them are done a lot of these procedures are done in day surgical, or they go home in few hours time, and these are the papers patients can give you problems. So the aim would be to identify these physical conditions. Also look at people who have with chronic alcohol abuse, chronic sedative abuse, or the recreational drugs, because the requirements for sedatives are going to be quite high, and if you start using your conventional routes, they're not going to sleep, they're not going to touch them also. I have known patients who are narcotic addicts, even 30 and 40 milligrams of morphine within a kind of 30-40 minutes. It doesn't touch them also literally. They're still talking to you, and so you know, those sort of things you need to identify, especially doing on a day surgical basis, these procedures. Goes without saying that you're going to assess the ASA physical status, because there are enough papers to say that higher ASA status increases the complication rates, the perioperative period, and ASA 3 and 4 patients are regularly coming. Some of the patients are coming from intensive care units, they are admitted with sepsis, with NORAD, and 4 pumps on this side, 3 pumps on that side, and they are coming for endoscopic procedures. So those are the ones who are likely to cause more problems, and there is enough study that that the higher risk patients are going to higher complications. Also, it depends on what procedures they are doing. Certain procedures, say like diagnostic upper GI, is going to be much less stressful for the patient than having endoscopic ERCPs, where the complication rates can be as high as 5% when you look at pancreatitis, sepsis, perforation, or bleeding. It's as high as 5%. So you know, it also depends on, you're going to evaluate from the point of the procedure as well. Routine laboratory testings are usually done. Having said that, the gastroendoscopy endoscopy are very reluctant to do any investigation of these patients, because it is looked at as a diagnostic or a therapeutic or a minimally invasive. So you know, why do you need it? Patient is walking in XYZ, and it's more with cardiac testing. You try convincing the endoscopists to do a echocardiogram, 2D echo on a patient before or an angiography to evaluate the heart disease, they're not likely to do it. If you have an esophageectomy, they probably will get it done everything. But general reluctance is always there in these procedures. But having said that, if you think really that you're going to do high risk procedures like ERCPs, probably it is sensible to get these investigation done. Otherwise, generally what we rely on is your functional status of the patient, where if they are functionally well, if they come walking in, if they don't get breathless by the time they get up on the table, if they are okay, simple things probably will guide you. And eventually, if you look at the overall, these procedures are considered to be a low risk procedure from the cardiac risk. Having said that, the revised cardiac risk index, which we follow the criteria, does underrate the risk for advanced endoscopic procedures like ERCP. Obviously, airway urination is going to be the most important aspect in the preoperative area, because majority of the complications in the endoscopic or in remote locations are related to the airway. Almost twice higher incidence of problems with airway than compared to your in theatre. Preoperative fasting guidelines, like any other elective surgery, this is the latest one from the American Society of Anesthesiologists. Each country has their own guidelines, but generally 2-4-6-8 formula which we follow. There are 2 hours for clear liquids, 4 hours of breast milk, 6 hours for non-human milk, infant formula, light meal. Now, certain countries where what we consider light meal can differ, or somebody can have regular food or a light meal, just toast or cereal, or you can have a full meal. What do you mean by heavy meal? That can vary. Even though alcohol is clear liquid, it does not include, don't get me wrong, I've said clear liquids, but I'm just mentioning it, I'm not suggesting anything, but alcohol doesn't count into your clear liquids. And obviously all these things are going to matter only in healthy elective surgery patients. But if there's any GI condition or upper GI condition where likely to have impaired gastric emptying, like gastric outlet obstructions or some esophageal achalasia, then obviously these needs to be modified, and also need to be modified according to your infrastructure as well as your what system, because you know the mindset change is going to be very difficult. Even though I may allow, but some of my colleagues may not. Surgeons are still very difficult to, because they are still in that same area that they all have to be fasted overnight, whether it's the next day 5 p.m. case or whether it's an 8 a.m. case. You know, they don't believe in giving in the morning fluids, the dryness of mouth, these things is all we discuss. But generally, a lot to do with the scheduling primarily also, because you know, if they suddenly some case gets cancelled, they quite early and come and do it also. So you do your fasting guidelines according to where the setup you are. Most important, the communication between the two has to be very clear. Anesthetic management wise, a lot of these endoscopy, either they're freestanding endo, they are not in the hospital campus as well, they are outside. They might be in the radiology department, in hospital endoscopy suites or operating room suites. What I feel is that when you have a complex of operating theatres, a 3 or 4 operating theatres, the middle one can be the endoscopy, because not every patient they call you for. Only the advanced procedures they call you for, and the simple low risk procedures they may do it on their own with minimal sedation or no sedation, like diagnostic ones. So at least somebody is around, you know, if there is some issue, some patient is not doing well or some allergic reaction to whatever they have given, at least there's somebody help around. So having a complex inside the theatre, this thing, or somewhere nearby, is quite helpful, if at all. But I mean, we should encourage them to have at least a standby for all cases, you know, rather than. More important, these are remote locations. Generally, they are outside the operating theatre environment, and whether it is in the theatre complex or in the radiology, basic and emergency equipment and facilities should be available as if for general anesthesia, including intubation and muscle relaxant and ventilation. Having said that, if you look at any of the setups, the oldest anesthesia machine, because a new machine comes, and one which gets replaced, usually goes to the endoscopy. Maybe. It is probably sensible because you do not do general anesthesia with intubation every day. Most of the patients are managed totally intravenous anesthesia. Same thing with cath lab also. With the oldest machine, the oldest monitor, they all go to the cath lab. You know, some you have to struggle sometimes to start them, to all sorts of things. So, but you know, at least they should be in a working condition. Though I mean, the theatre they were working, but you know, you don't use them, so you know they. And more important, adequate personnel who actually can help in an emergency. So then it comes to where you can actually train your staff, and there is enough data to show that if you have really trained them, especially for airway emergencies and everything at all, your life is much simpler and the outcomes can be better. What will be the choice of anesthetic? Obviously, it will not depend on the patient factors, requirements of the procedure, the duration, the complexity, the position. Some of them want to do ARCPs in prone position. Now, sometimes it's easy to do in lateral, prone. Sometimes they have to change the positions from right, left, or to left, lateral. So a lot of factors will be seen. And generally, if you look at the procedure, they're divided into three parts. There are screening procedures, whether it's an upper GI or a lower GI, or diagnostic endoscopies, upper GIs. And there are advanced procedures like ERCPs, endoscopy, ultrasound. They keep adding to these procedures, you know, with the new equipments coming and new training. You know, very specialized procedures like stenting and everything which used to go to the theatre, now they are getting this. So, if at all your anesthetic technique, what you are going to do is going to be based on what sort of procedure, the duration. Often, I think it is the experience of that endoscopist. Now, I have worked with so many of them. Some of them are, whatever the procedure, they take not more than 15 minutes. You know, your thing can be changed completely, and some of them it takes 15 minutes for the scope to go in. You know, forget finishing the procedure. They're struggling. At times, patients can be difficult as well. The other day, they wanted to remove a stent and put in a new one, and then it went inside. And then it took a couple of hours for them to retrieve it. They couldn't do it at the end. So at probably 1.5 hours, they said, we just leave it now. Just put in another stent from the side and came on. So you know, all those things can occur. Once you start, then you're committed. You just can't do anything at all. So the various options depending on the procedures. One is unsedated or awake. That is also one of the techniques. It depends on countries, you know. In very high affluent countries, probably every patient would request for some sort of sedation or something. But if the low economic conditions, they're quite happy to accept. And having said that, I have also seen a lot of procedures being done where the patients are fully motivated and they seem to be fairly comfortable. At least they don't complain if they are motivated. It can be sedation, it can be like mild, moderate, severe, which I'll cover that in a minute. Most of the time we use totally intravenous anesthesia. Inhalation agents are rarely used, but there should be facility if you need to use, if you want to intubate or something. I have used with your BiPAP nasal mask inhalation anesthetic where I could not give anything intravenous to that patient because I couldn't afford a little bit of respiratory depression in a 94-year-old with multiple comorbidities. He was such a father of a VVIP where, you know, there are 10 doctors inside. In such of cases, we don't want to take, so inhalation, you know, just wears off quite quickly. And general anesthesia, endotracheal intubation, and if it's a lower GI, then you know you can, if you're not able to maintain, even suprachoroidal devices can be used. This is what I was saying: minimal sedation, moderate sedation, deep sedation, or general anesthesia. Now, it's very easy to understand what general anesthesia means, but you know there's a lot of grey area between moderate and deep sedation, and patient sensitivities can be different. And basically, when you intend to have a moderate sedation, can easily go on to this thing. So you should have facilities to monitor if at all it goes so deep. And if you give a little propofol and if the patient sensitivity is higher, then you know they can go from your deep sedation analgesia to almost general anesthesia where they're not responsive. So these are little bit grey areas. Monitoring. Generally, if you look at the most of the endoscopy unit, there is an ECG, heart rate, blood pressure, NIBP or saturation. These are the common monitors you see which are there. The small monitor, which is a truncated version of the usual big monitors, are there. Again, same thing. The monitor which was there in the recovery room, or which they have got a new one, which goes to the endoscopy area with with a little bit of loose connections and XYZ, very common. Generally, this is what I have seen most of the times. And whatever standard ISA monitoring you need to follow. More important, you have to remember, respiratory events are the most important events in the perioperative, especially outside the theatres. Airway emergencies, laryngospasms, bronchospasms, coughing, gagging, desaturations, hypoxemia, hypercarbia, apnea are the commonest. More than 50% complications are respiratory. So what I feel that monitoring of oxygenation is very easy with pulse oximetry. You can give supplemental oxygen as well. But if you can do some sort of monitoring of ventilation, it is difficult for upper GI endoscopies where you are sharing the airway, and basically when the endoscope goes into the mouth, it is not very easy to monitor entirely. However, in colonoscopy cases and everything, there are good monitors available. There is actually good like a capnogram, and then we have in one of the IVF set up the fantastic monitor from Philips, where actually you can, there's a nasal prong with a bi-manual, you can give 2 tubes, one giving oxygen, the other one actually detects the carbon dioxide. You get almost tracing like an entitled CO2 tracing in the theatre. So ventilation monitor, if it is possible, will be a great advantage. Apart from though none of the societies, none of these recommendations or something do endorse or say that it is a compulsory thing because of logistic problems there. But if you can have a ventilation monitor, I think that would probably reduce a lot of problems and complications. Airway management, again, most of the patients are done without an endotracheal tube with total intravenous anesthesia and usually either intravenous drugs. But whether to perform, some centers perform all the advanced endoscopy procedures are intubated. Some of them don't. It all depends on how your setup is, what your gastroenterologist does. I think it's a communication thing, and whatever is comfortable, the duration, time and everything. But definitely the ones which I intubate are the ones where very complex patients are that we tend to get them to do it in the theatres. So they get their machines and everything in the theatre and do it. Children I do definitely intubate, because the moment your upper GI endoscope goes in, it presses the trachea from behind and they're really going to stride out and this thing. So children and high risk patients I intubate, all others probably manage it without this thing. But it all depends. Some centers intubate all the patients. Colonoscopies they may not, but they do intubate patients.
So definitely.
Sorry? Predicted difficult airway or mask ventilation, if you think, or you predicted intubation, this thing, you should be able to intubating them. Positioning also, if it will be shared airway, or more important, risk of aspiration. These are some of the conditions where probably full stomach, non-fasted emergency patients, obese, where the intra-abdominal pressures are higher, gastric option higher. These are the questions you should consider for intubation. So if it is high risk of aspirations, all advanced procedures, complex procedures like to those are the ones you should be considering intubation rather than managing them on. The goal will be to provide immobility, analgesia, amnesia, comfort without compromising therapy. But obviously each patient needs to treat as important. What are the specific anesthesia concerns? Diagnostic endoscopy, there are coughing, gagging, retching, vomiting, colonoscopy, bloating and aspiration. Some of these advanced procedures, they need to be repeated insertions and removal of the scopes. In those sort of cases also, you need to keep deepening the plane at the time of insertion, so that is what is necessary. And certain procedures like dilatations are quite painful when they dilate. And sometimes it causes a lot of vasovagal symptoms like bradycardia, where they need to be careful. So such cases, you need to be a little bit careful while doing it only with this thing, but you need to keep things ready. If you have an endoscopic drainage of large pancreatic cirrhosis, they definitely should be intubated because it can be quite long procedures. And nowadays what we do is per oral endoscopic myomectomies. These are the procedures. It's like an alternative for open surgery for myotomy. This is by achalasia, where it's a delicate procedure. Patient needs to actually still paralyzed probably. It's a high risk of aspiration because of the achalasia as well. And significant number of them do develop pneumoperitoneum, pneumothorax, and pneumomediastinum. These things. And generally these patients are kept in the hospital. So if you have any of these advanced procedures being done, then definitely intubation might be an option. Drugs, well, I said topical local anesthetic only. Propofol, patient satisfaction is much better. It is short-acting, predictable, recoveries are faster, clear recoveries, minimal nausea, vomiting. Having said that, it is an unforgiving drug. It is potent drug. It can cause a lot of apnea if not used properly. If you are not trained to use it, it can cause a lot of problems. We use a little bit in boluses, infusion or combination. Previously diazepam was used because of longer acting. It is almost replaced with midazolam. And opiates like fentanyl and remifentanil are used short acting. But generally, if at all, opiates and fentanyl and midazolam combinations are very commonly used instead of propofol. But those are the ones where the gastroenterologists give their give the professor. They are more comfortable with giving midazolam only or fentanyl. But if you use combination of small dose of fentanyl or propofol or something, fentanyl, propofol and midazolam, then you can reduce the doses of each, and the patient is much more comfortable, the recoveries are faster. If you use only fentanyl, there are enough papers where only remifentanil is used. This will intense analgesia. However, it doesn't cause amnesia or sedation much. So patients might be still aware. If you explain to them they're going to be awake, but you won't feel anything or you won't have any pain, they're still okay with it. Dexmedetomidine has been used to try to understand it's a potent drug with a lot of cardiac side effects if at all, if not used correctly. And depending on the dose used, it can be a variable time of recovery as well. Ketamine has been used in select patients. However, generally if you use only ketamine, then there can be side effects along with hallucinations. It's not a very, because most of the patients go home in 2 hours time. It may not be a very popular drug, but yeah, it has been used.
So we are out of time now.
Just 2 slides more, sir. As I said, complications, they are multifactorial. One, remote locations, unfamiliar procedure rooms, personnel, inadequate availability of space for routine. When we started our endoscopy room, the room was quite big. Now there are so many equipments, along with CM has come in, everything at all. Now it's no place for you to move around as freely as it used to be before. And inadequate monitoring can be a problem. If you look at the complications analysis, majority of them are basically related to your respiratory complications and oxygen ventilation. And most important, they said that your child is having preventable with better monitoring. This one large study, 2,100 patients in a teaching unit, where what they said the cardiac complications are almost 12%. When they said the cardiac complications is significant hypertension. Transient hypertension is quite okay. More important, this is one study which was by your anesthesia practice. If you have a regular anesthetist who is doing regularly cases, the mean time of the procedure, the intubation rates are much lower and the complication rates seems to be much lower compared to an occasional anesthetist. So if somebody is doing this regularly, it is important. Post-operative care unit as well, you need to have full facilities to monitor the patients before they go home, including a supplemental oxygen and somebody to look after the patient in the same. Generally, patients are monitored for an hour or so in the recovery room. They are given IV centers, but if they have any reversal agents, say like flumazenil, and flumazenil is fortunately available in neon laboratories, not because they have a stall outside, but flumazenil is available in neon laboratories now. And it could be probably one of the drugs which need to be kept in the endoscopy unit along with naloxone. So if somebody is got over-sedated, you can at least use them. Those patients should be monitored for at least 2 hours if you need to have a reversal agent. This is just a controversy. Whether it's a subspecialty in evolution, because of use of propofol is increasing in the endoscopy, that could be one of the subspecialty of anesthesia, where people can be only doing only these things. But this paper which came in is 2017 October, sedation for routine endoscopy review on the efficacy. We showed that the cost can be significantly reduced if you use non-anesthetic based sedation by assistance with a nurse or something, which I don't think we should encourage. This is probably from the insurance company sponsored. So to summarize, basically, you need to have a good pre-anesthetic evaluation of these patients. You need to have a lot of facilities, proper facilities for airway management and manage the complications. And generally, these may be associated with higher risk of than other procedures. These are some of the preparation for remote location, the ASA standards. So you need to have all these, about oxygen source, and these are very fairly standard. This is given all the whatever recommendations are given for remote location. More important that when you go to remote location, you're stepping out of your comfort zone. That is what creates a lot of problems. And most important, remember, life begins at the end of your comfort zone. So if you really want to get that, more important, if you are going to have good outcomes, have a teamwork, have good communication with your gastroenterologists and anything. Otherwise, you'll end up you doing something else, and then I don't think this is not our metro thing. Thank you very much.